Hi, everyone. Good afternoon. I hope you're all doing well today. Again, my name is Lori Bailey. I work for UCB. I am the patient advocacy lead for rare epilepsies. Today, we are here to talk about the C.A.R.E binder, which is a new resource that we have collaborated with the rare epilepsy community to bring to you today. So in this workshop, we're going to discuss the development of the C.A.R.E binder to help primary caregiving organize their patients' health information, information on daily needs, reports, and other documentation. And what we hope is that this workshop will leave you with the knowledge and resources to develop a C.A.R.E binder for your own child who's entering adulthood. So the way this session is going to work, this workshop, we're going to break this down into 3 different sessions. We're going to start with medical transition in the first session. The second session is preparing for early adulthood, and then the third session is preparing for later adulthood. So I think my helpers have all provided you with a hard copy of the binder. So the first thing that I want to mention about this binder is that for the workshop, we have printed the hard copy binder for you so that you can follow along. But this resource is actually meant to be an electronic resource, an electronic PDF that is fairly interactive. And the reason for that is because there are a lot of resources that we want to connect you to. So there are links throughout the binder to help you connect, and then as well some other important information to access. So what we're going to do is I'm going to start by just kind of giving an overview of the binder. I want to tell you a little bit about its history and to show you how to navigate the binder. And then once we kind of get through that initial discussion, we're going to turn to our wonderful panelists here who are going to share their expertise and experience with you. So one thing I do want to ask, we're going to wait until we get to the Q&A section to answer any questions. So in your bags that you got, your registration bags, you should have had a notebook and a pen. There are pads and pens on the table. So as we go through the session today, please feel free to write down whatever questions we have, because we definitely will have some good time set aside to hear from you. Okay, so with that, I hope everybody has their binder. Let me just get this. So when you get through the binder, oh, sorry, I'm going to have to get a, oh, sorry, my microphone is falling. There we go. So to start with, I just want to show you how to navigate the binder. So the first 2 pages will walk you through the navigation. It's a little bit, it might seem a little bit daunting. It's 143 pages, but this process is very daunting, preparing for long-term adult care. So the first 2 pages will show you how to navigate the binder. So if you notice up here in the upper right-hand corner, we've added some different navigation buttons to help you. So if you click the back, that'll go back. Of course, the other one will go forward. The one here in the middle is kind of your home button. It's going to take you to the category menu where you're going to be able to find a list of everything that's contained in the binder. So I also want to bring your attention to these 2 icons here, which is another reason why this electronic version is going to be really important for families. As you go through this journey, sometimes it feels like you're alone, and we want you to know that you are not alone in this journey. There's a whole community out here that is there for you. When you see this heart icon, you can click on it, and when you click on it, you are going to have a message from a caregiver who has walked in your shoes, who understands this journey. When you see the blue icon, when you click on it, you're going to get a message from a healthcare professional who cares for children like yours. So hopefully this will help provide some guidance, give you some tips, and make you feel more connected to the world as you're sitting here going through this resource. The second thing that I want to really highlight is that The first section of the binder is called the C.A.R.E guide, and this guide really is going to help you navigate the rest of the binder. It is really your roadmap to getting through all of the information. So no matter where you are in your journey, we would love if you would start with that binder and just to review it. I'm going to review a little bit of it with you today and show you how to navigate it. So in the beginning, you'll get an introduction. What this resource focuses on are three main areas as you prepare for future planning for your child. The first one is medical transition, pediatric to adult care. The second area is focusing on long-term care for your children ages 22 and beyond. And then in the third area that we focus on is transfer of primary care when primary caregiver is no longer able to care for their child. And this is an important section because transferring primary care can happen at any time, and it can be, yes, it can be a permanent change, but it can also be a temporary change. You know, what if you break your leg? You know, what if you get sick? And someone has to stand in your shoes and provide the same consistent, wonderful care that you have provided for your child all their life. You want to make sure that you have a plan in place so that anybody can step in and do the best they can to care for your child. So those are the three areas that this C.A.R.E binder will address. Now, once you get into the binder, one of the most important things right up here in the beginning is a checklist starting at age 13. So you might recognize this checklist actually that was introduced at the previous conference, I want to say 2 years ago in Fort Worth on the adult workshop. And it is really a critical place to start because it's going to help you think about all the things that you need to do as you go through, as your child ages into early adulthood. Now, as I say that, I just want to make a statement to say, this is not the end-all be-all. This is not going to have everything in it that you're possibly going to need as you go through this process because it is very complicated. It is very complex, and you know that better than anyone else. But we hope that at least it'll be a start in the right direction. The other thing that I want to mention is that this binder, this is the first time we've ever taken on an initiative like this. You can imagine it was a pretty daunting task to pull this together. We certainly didn't do it by ourselves. We collaborated with the Dravet Foundation, with the LGS Foundation, with TSC Alliance, and many other organizations to bring this together. We also did not start from scratch. We did not try to reinvent the wheel. We don't want to do that. So we did extensive research before we started this project to see what is out there. What are some wonderful resources that we can adapt for this community? So about probably half of the binder are those resources, and then the other half are resources that we developed from scratch. And so the reason I mention that to you is because this is the first time that we've had anything like this to share out in the community. And like I said, it's the first step in the right direction, but we want to continually look at this process, and we want to try to keep improving it as time goes by. So one of the things that I'm going to ask of each and every one of you and anyone who accesses this resource is to provide us with feedback. So it's not on your hard copy, obviously, but there on the back of this electronic resource is a link to a survey to provide feedback. That link will be available on the binder itself. It'll be available where the binder is going to be housed on viprarecare.com, and it'll be available on the Dravet Syndrome website. They will also have a page dedicated to this resource, and you'll be able to access it there. But I really ask that you all provide us good, bad, or ugly, what was great about the binder, what was helpful, what do you think would be more helpful, because this binder will be reviewed every 18 months, and while we may not be able to include every every suggestion, depending on how unique it is maybe to your specific situation. We will take as much into consideration as we can to keep improving the binder. So I just want to make sure before I forget that we mentioned that. So going back to the checklist, starting at age 13, and many of you may be asking, wow, that is very young. And many of you may be thinking, well, my child is much older than 13, and I haven't even started this process yet. And that's okay, because wherever you are, you can still successfully get through these transition periods. We start at age 13 because that's the age that's recommended by the Child Neurology Foundation to start having those conversations with your healthcare provider. And one of the most important things that you can do is to confirm when your child is going to be aging out of services. And so starting that conversation really early, if you know at age 13 or when, as early as you can what those age cutoffs are, then you'll know what your specific timeline is that you need to work through to make sure that you're able to meet the deadlines for some of the things that are going to need to be taken care of as your child ages into young adulthood. So anyway, if you go through, you can see it goes each year. There's a checklist. And you'll see that it's not just medical transition. You're going to see that there are items on here that are related to guardianship, that are related to financial considerations, that are related to legal considerations, long-term care such as living arrangements and things of that nature. And so as you go through each year, it'll give you some guidance on the things that you need to be thinking about to prepare to make sure that you're ready when you get to the point where you need to actually make those decisions. Okay, let me just click through that list a little bit. Once you get through that list, you're going to get to this section where you take a little bit of a deeper dive into long-term care planning. It will talk about how to create a letter of guidance and all the things that you need to include in that particular task. It goes into the financial and estate planning, as I mentioned. Talks about ABLE accounts, guardianships, conservatorships, and then as well into housing considerations. The other thing that you'll need to think about is advanced decision making. And so we go into provide some information about that. And then when you get through the care guide and you get to the end, that's when you'll jump into the menu, the category menu. So let's just take a look at this category menu for just a minute. I want to show you what is inside here. So you can see there are several different sections. And because everybody's at a different place in their journey and everybody's going to organize their information a little bit differently depending on what is important to your family, we decided to put everything in alphabetical order so that you can easily find the information. So you can find anything and navigate your way through the binder by going to this category menu. You can click on a specific section and just look at the detail for that section. You can see for this one, conversations, we have a section about having conversations with adult siblings about future care. If your family has siblings and they are going to be part of future care, this particular section will really help guide and know how to have those conversations. We also have conversations with extended family members and with healthcare professionals. How do you bring this up with your healthcare professional? And what kinds of questions do you need to ask? How do you need to be prepared to have those conversations? We also have a section on daily living. And you can see it gets very, very detailed. And that's because what you do is very complicated. Caring for your children takes a lot of organization. And so this section will help you with all those different tasks that you need to document for your child. There's a section on disease management. There's a section on important contacts, of course. There's a section on long-term care planning, which the C.A.R.E guide is part of, and then you can see developing a lifelong support network is in there, financial, legal, and long-term residential living. There's a section on medical transition, peds to adult, and then a resource section. So as you can see, it's a pretty comprehensive guide. Hopefully we've organized it in a way that you'll be able to navigate it. And of course, anytime that you're going through any of these sections, one of the most valuable resources you actually have are the people in this room. It's your community. It's the Dravet Syndrome Foundation, or the ambassadors, or the people that are in your local area. That is your number one resource as you navigate this really complex journey. So we encourage you at any point to please reach out to the foundation, reach out to local people, your local regional ambassadors, to ask for help, because they're the ones who have walked in your shoes and will know how to support you in the best way possible. The other thing I want to mention before we go into the medical transition discussion with our panelists is that this resource was created it's not going to be one size fits all, first of all. You'll notice some of the pages, it looks like there's a page number missing. There's not a page number missing because everybody's going to use this resource differently. You can pull out the sections that are pertinent to you, and those are all user-defined. You can put in whatever page numbers that you want in order for this to be unique and customized to your particular situation. So the other thing, there's one more thing I want to mention, and let me just pick a good example. You know what? It's very big up there for you, but for me, it's very small, so I'm going to blow this up a little bit. Let's see. So here is a great one. I love this one. Summary of introduction to my loved one. So you'll see that this PDF is a fillable PDF. So when you download the resource, save it to whatever device that you want, and you can type in here and save your information. There are areas like on this one where you can upload a picture. You might be describing how your child communicates. Maybe your child communicates with different facial expressions or things like that. There are areas where you can upload photographs of your child so that when someone else takes this binder and takes a look at it, they'll know, oh, this is how my child communicates. So what you can do too is you can save it, you can come back, you can edit it if you need to update it. So that's why, again, the electronic piece is hopefully really valuable and useful to you. You can also have this binder put together electronically, and you can just print specific pages and email them to people. So you can share some of that information, whatever information you choose to share, with the people that are in your support network. So I'm going to kind of stop there because I feel like I've been doing a lot of talking, and I want us to hear from our wonderful panelists. So we're first going to start with the medical transition. And each panelist is going to introduce themselves, and they're going to talk a little bit about their experience they have, where they are in their journey, and how they can tie their experience together with this new resource to help you use it in the best way possible. So I'm going to start with Dr. Burkholder. He is going to walk through the medical transition piece. So Dr. Burkholder, can I turn this over to you?
Sure. And this is on. Very good. Hi, everybody. My name is David Burkholder. I'm an epileptologist at Mayo Clinic. You might have seen me yesterday. I've been at Mayo for most of my time since 2009 in some capacity, either as a resident or a fellow, or then eventually staff for the last 10 years or so. One thing to discuss today had to do with the medical management piece and when it came to transition. And, Dravet is a very interesting epilepsy. Obviously very difficult to treat, very challenging factors related to it, but it's also unique as an epilepsy in that because of all the work that's been done by people like Marianne and like Veronica and like Dr. Whirl, it actually has a roadmap. For what we have right now for available treatments, it has a reliable roadmap, which in some ways makes my job as a provider that much easier, at least for that piece of it. Obviously, it leaves quite a bit yet to be desired, and there's always something around the corner, and you never know what the next big thing is going to be. But it's one of the few epilepsies that really has a fairly distinct roadmap of treatment. And you'd think that that might make medical transitioning a bit easier, but in reality, I think there are a lot of issues with medical transition that make it difficult. That sometimes doesn't have anything to do with medication or the treatment avenues. I think communication becomes probably the biggest piece and the biggest barrier in transitioning. I was just speaking with Miss Dodd in the corner over there before coming up here, and one of the things that she asked is if in our transitions we have our providers meet both the adult and pediatric provider with the patient, because of course what better way to communicate than have everybody in the room at the same time. Fortunately, I'm at a center where if the patient wants that, if that's where their comfort level is, that's something that we can arrange, because our pediatric neurologists are 8 floors above our adult neurologists, and so we can arrange those visits. I've had patients where I've gone through several visits with them, with Dr. Worrell or Dr. Nichols or whoever they've been seeing before they officially transition all the way over to me alone. And a lot of other places that might not be physically capable, right? A lot of practices, you have a pediatric practice that's separate from an adult practice. You have neurologists that are in 2 different areas, parts of 2 different practices or 2 different systems, and never the 2 will meet. So I'm fortunate that is something we're able to do if we need to, but realize that might not be the reality for everybody. So the communication piece does become important, and I think one thing that's nice about the C.A.R.E binder, in particular, Lori, what you just showed us with this last page is that introduction page, right? That you can take that, you can deliver that to whoever their adult providers are going to be, and they're going to say, this is what I want you to know about my child. This is what my child wants you to know about them, right? And not just the disease, but them as a person. Of course, having information about the disease is important. We always want to know, what have you already been on? Obviously, what are you on and what doses are you on? What have you already been on? What really didn't work well? What are the things we need to make sure we steer clear of and document very clearly that we need to not do? But also, who is this person sitting in front of me? Right? What do they like? What don't they like? Where are the things that we're gonna meet, and we're gonna build rapport, and we're gonna grow together with that? The other part of communication that becomes important, because it's a two-way street, right? It's not just us communicating with you with what we know and what we think should happen, but realistically what you know and what you think should happen. Because most of the time, that's the most important thing that I get out of somebody with our visits, right? These are complex children, complex epilepsies, complex medications. I'll use that word over and over. And I can think that I know everything there is to know in the world, but the person sitting across from me is going to know a lot more about their child and their epilepsy than I am going to, right, as an individual. And sharing that's important, because that's how we grow on our end as providers as well. One thing that I tell my fellows is, 90% of my job is just offering to do something. Right? It doesn't mean anything has to change. It doesn't mean we have to do anything, but it's just offering to do something, right? What that something is often is a negotiation and meeting in the middle between the patient or the patient's caregiver and what their experience has already been, right? And so sharing that experience, being able to communicate with that experience with us is so important for us understanding where you are and where you want to be, right? Unfortunately, so often that has to take place in a 30-minute time slot, right? And that's just not very feasible. So it does become important to kind of go in prepared and know what you want your points to be and what you want to talk about. But one thing that I did mention yesterday in response to a question was, there is nothing wrong with delivering this information and delivering this communication well before you have an appointment, right? I'd much rather be prepared going into that appointment and making sure that we're on the same page and I know what they're going to want to talk about. I know a little bit about the person sitting in front of me. and we can maximize our time that way. So there's nothing wrong, weeks to even a few months in advance of delivering that information, saying, hey, listen, we're going to have this appointment. Maybe you're in a position where there's not a lot of communication between the pediatric neurologist and the adult neurologist because they're separated in space and system or whatever. But these are the things that are important. We just want you to know about. This is some of the medical history leading into this. These are the medications, and these are the things that we want to go over, in our first visit together when we meet. It is important, talking about the timing of transition, it's in some ways never too early to talk about it, or never too early at least to realize that it'll come. But in thinking specifically about the medical side of it, right, you definitely want to give yourself enough time that prescriptions can be transferable and you're not going to run out of stuff. So I can't tell you how often, not just with Dravet, but epilepsy in general, we run into a scenario where they are due for refills. I'm seeing them for the first time, put in the refills, they need a new prior auth. Whoa, right? They're out of medication, we're up against a wall a little bit, right? So as much as possible, and of course a lot of this timing is not controlled by you, but as much as possible, having some time leeway to be able to make sure that those transitions can occur safely, that nothing's going to run out. Of course, being already established with a pediatric neurologist, most of the time, I think most of us would be in a position, even though if we're transitioning away from that person, but we're having problems receiving medication from a new provider, doing what we can to help out with that, right? But ultimately, making sure that you're allowing yourself enough time and enough window to make sure that those things can happen safely, right? And another big one these days is fenfluramine. The Fintepla RIMS, the monitoring system. You want to make sure your new adult neurologist, if your child is on Fintepla, that your adult neurologist is familiar with that they know they need to be registered with the monitoring system and with Fintepla, and that they've done the required training. It's very straightforward. It's very simple to do. Fortunately, it does not take much time, and I appreciate that as a physician. But that's also something that's good to let us know in advance, just in case we're not already plugged into it, so that you can make sure that that's going to be available to you as you need it to. So if I had one thing to say, I'd say communication, right? Above all else, communication is important. And as much time in advance as you want to do it and are comfortable doing it, I would reach out to whoever you may be transitioning to just start that conversation.
Thank you, Dr. Burkholder. I wanted to mention that a few of the points that you made, that there are some tools in here to help you with those conversations and help capture that information. So I love that how you brought that up about being prepared and you want to know in advance. So when you go through these different areas of the medical transition, the caregiver medical transition readiness or the epilepsy living in history forms, these are some things that are really important to think about and prepare in advance. So thank you for that. Appreciate it. All right, now I would love to hear from our parent caregivers. So, Jean, do you want to kick us off with that? Thank you so much.
Sure thing. Is this on? Hi there. Now can you hear me? Yeah, my name is Jean Stock. My husband Greg is sitting right down there. Wave your hand. And our son, Danny, is 43 years old. So I know he's a lot older than a lot of your children. He's older than some of you parents in this crowd. And I bet Greg and I are the oldest people in the room. So we have been through a different type of journey because we're a generation ahead of you. Danny was not even diagnosed until he was 30 years old. So as we were raising him, we were always told he was borderline Lennox-Gastaut. We had him on all 4 of those medications that were contraindicated for Dravet syndrome. But all along, we've just always done the best we can. Your generation, it's just remarkable the support that you have from the foundation. It's very different for you. I'm just blown away by how much DSF does. I'm blown away by this C.A.R.E binder. Laurie let us take a sneak peek at it before we got up here. And it's just a different world for you all. So, like a lot of you, we have tried multiple different drugs, different combinations of drugs, different dosages. We've tried the VNS implant. We've been on the ketogenic diet. You know, again, I've been through a lot. And we had our best luck ever with Belviq, or lorcaserin. Well, that's the drug that has to be taken off the market because they're not going to manufacture it anymore. So we are going to be doing the transition to Fintepla over the summer. Hopefully that will go well. One thing I want to mention as far as transferring from a pediatric to an adult neurologist is, of course, insurance is so important. My advice, of course, is to get on Medicaid as soon as you can. In Florida, we are from the Tampa Bay area, and I was not able to get Danny on Medicaid until he was 18 years old, and we applied for the SSI benefits, the supplemental security income. But I continued to insure him until I retired. I had school board insurance for him, and Medicaid was always the secondary backup provider. So we were able to get good care. Then what happens, and again, your kids aren't ready for this at all yet, but once I retired and started receiving Social Security benefits based on my own work account, that made Danny eligible to transfer from supplemental security income to Social Security disability income. And after a 2-year waiting period, then your child is eligible for Medicare. So that's the ideal situation where they are covered by both Medicare and Medicaid. There are wonderful insurance plans out there. We happen to sell insurance ourselves. But they're called dual SNP plans, or DSNP. It stands for Dual Special Needs Plans. And these are plans that are available for patients that are on both Medicare and Medicaid, and have a lot of wonderful extra benefits like $3,000 in dental work per year, hearing aids, the PERS things, you know, I've fallen and I can't get up, transportation, all kinds of things. So as far as our own personal transition from a pediatric to an adult neurologist, and like Dr. Burkholder mentioned yesterday, it's so important to make those changes to adult doctors because diseases present themselves differently in children than in adults. And if there are other complications, it's best to be with the right age group. Our primary care physician, I just talked to my own primary care physician, and I had told her about Danny all along, and she was very willing to accept him. So that was a very easy transition. As far as the neurologist goes, we were going to a doctor, a pediatric doctor in Tampa, and he was really the only one in the whole area that specialized in pediatric epilepsies. And he referred all of his patients to a doctor in St. Petersburg once they aged out. And that doctor was director of a level 4 epilepsy center. So for us, it helps to live in a highly populated area as far as when you're looking for good medical care. At the time, his occupational and physical therapist stayed the same and stayed with him. And at that time, he didn't need any other specialists. So our transition was really quite smooth. One other thing I wanted to mention along the insurance line and medical care line is if you're looking for a doctor, I don't know if any of you have been on those websites that rates doctors. There's healthgrades.com, there's vitals.com, there are Google reviews, but a lot of times through those rating scales, you can see what other patients have said. And you might find that, you know, certain doctors are just so compassionate and so willing to accept these complex situations. So that's about all I have.
Thank you so much, Jean. Really appreciate it. Thank you. So we're going to pass it over to you, Michelle. Okay.
Good afternoon, everyone. My name is Michelle Fiolariti, and I am the mother of three children. Two of them are out of the house, and my youngest, Andrea, is 21, and I am right in the middle of doing all of what everyone's talking about. I mean, literally on Tuesday, I will be meeting with a adult PCP. I have never met this person. The process has been kind of a little more daunting for me, because if I thought about doing with my primary care, I think he's getting ready to retire, so that was not an option. Andrea was diagnosed, had her first seizure at 6 months. She has the SCN1A huge deletion. She has tried all the different medications, and Lamictal is the one that comes to mind, which I guess is contra, but we didn't know at that time, so it was just a lot of stuff going on. But as she's gotten older, she's having more problems with some of the comorbidities, especially gait, which she no longer walks. She has problems with pulmonary, respiratory. She has had aspiration pneumonia quite a bit. She had it a lot. She was in the hospital for a year with aspiration pneumonia between Boston Children's. I'm from the Boston area, I forgot to mention. From Boston Children's into a Franciscan, which is a rehab place. And in doing that, she wound up losing she decompressed. She no longer walks. She can't bear her own weight. She has terrible core strength, and which I think is leading to a lot of her respiratory issues. But back, I noticed on the chart around 13, when this was all before Andrea's issues with pulmonary happened, I would be asking her pediatric neurologist, so how long are we going to be able to stay with you? Because I was always looking far down the road, and at that point they kept saying, well, we'll keep her until about 30, 35 years old. And I'm like, well, okay, and didn't think anything of it, because I kept asking the question all the time. But then about 3 or 4 years ago, the doctor that she sees for her enteral issues strongly recommended that I look into this program that they're starting at Boston Children's called Bridges, which it pretty much is like the name sounds, going from pediatric to adult. And when I first reached out to them, they're kind of like, you're kind of early for this, because at that point they were getting the program going, and they had, for instance, the GI doctor that I was seeing, she had a patient who's 28, and so they were trying to get those patients to transition to adult doctors. So in the last year and a half or so, it's finally turned to me, and I've had many meetings with the doctors because they're both pediatric and adult certified doctors, and the one that we have now happens to be her pulmonologist, who is, again, pediatrics and adults. So that one's going fairly straightforward, but with Andrea's respiratory stuff, and with she has endocrine issues, she has bone problems. So we had a laundry list of doctors, and I've learned through this program at Children's that a lot of these things that I'm asking about are going to be dealt through the adult PCP. So I'm like, okay. But the other thing that this program also helped me with, which is making the transition a little easier than I expected. Andrea and I met with an adult GI, and at first I thought she was going to say no, but with Andrea's issues of constipation, she's going to keep her on. We talked about stuff like that. The other thing that the Bridges program that's been helping me is they pulled together a cheat sheet, or kind of probably a lot more not as detailed, but it talks about, and I helped with it, all the different things, all the different doctors that Andrea sees, and that helped really well with the GI doctor. I'm hoping the same thing happens next Tuesday when we meet with the adult doctor. But the other thing that, which will be good, I'm looking forward to that because we're having kind of like a wrap-up appointments for her for several of her doctors. Most of them fall into August, so once I meet with the adult doctor and then we start talking about saying goodbye to the pediatrics. The only pediatric doctor that I'm still a little on the fence is her neurologist, who I absolutely adore. What I'm hoping happens is that she's working with some of the adult neurologists at the hospital that we're going to, so that that transition will be a little bit easier. And the other thing I'm hoping is, because her neurologist is really, really deep in the research for a lot of the genetics that's going on, and I'm hoping that my ultimate goal is to have a neurologist that they can go back and forth, so that if I have a question, my aunt said this, and they will be able to collaborate a little bit more. I'm not sure where that's at. Like I said, we're just getting going, and we'll see what happens.
Thank you so much, Michelle. So you heard from two different parents, different stories, and I know that probably every person in this room has their own story, a different and unique situation. So again, one of the best things that you can do is reach out to other parents, especially maybe that are in your area, because every institution is going to have a different policies. Every local government may have different plans or programs, as well as, every state is going to be different. So before we jump into some questions, what I wanted to do was just kind of show you a couple of areas of the binder that are relevant to the medical transition. That'll be helpful. Of course, the CARE guide, which we talked about, like the pages 7 through 12, that's where you're going to get the best sort of roadmap, if you will, as you go through the medical transition. The other one I wanted to mention is this caregiver assessment on medical transition readiness. So this is, in this particular form, this is going to help you as a family determine, am I ready? Is my child ready? And so as you go through the form, it'll ask you some different information. Do you have your medical records organized? So go through that checklist, because that will be really helpful to support and ensure that you have the most successful medical transition as possible. The other thing that you want to do is, it's very hard, I think, and probably Dr. Burkholder can speak to this, but very difficult to go through a medical transition when your child is in crisis. And I know that we do, there are a lot of times when our children are in crisis, but probably thinking about ahead, speaking and communicating with your healthcare professional, what can you do to try to keep your child as stable as possible when you go through that transition. And then, of course, I had mentioned this before, but having the conversation with healthcare professionals to prepare is really great. And then the other thing I wanted to mention was this epilepsy living in history form. So Dr. Burkholder, I don't know if you've been working with families to kind of help prepare a summary history when people are going through transition. But there is a form in here that you can work on with your your epileptologist or your neurologist to ensure that the adult provider is getting a summary of everything. So I don't know, Dr. Burkholder, can you speak to this? Because I know that you all probably have a file this thick, but a file this thick probably will be very overwhelming to an adult provider. Can you speak to that, Dr. Burkholder?
Yeah. I'm in a fortunate position. As a single system and working with Dr. Worrell, Dr. Nichols, Dr. Wankissel, a number of very competent pediatric epileptologists who see a number of Dravet patients, something that's always been nice in our transitions, when they've been seen by our folks already, that summary is already there. A lot of us tend to kind of document an epilepsy, kind of semi-permanent epilepsy summary in all of our notes so that it's kind of just there, and then talk about the interval history as part of that. So within our system, that's been fairly easy, but again, those transitions within systems are ideal, but not necessarily always what actually happens. And so having some sort of summary document does become very important, because you can show up with 1,000 pages of records over the last, this is what the last 20 years have looked like, and somebody's eyes are going to glass over real quick, and you're going to get lost in all that information. You really just want to know what are the points that are important in this timeline, and documents like this are very important for that and helpful.
Great, thank you. Well, I would like to open it up for Q&A. Does anybody have any questions? Yeah. Do we? I think we have a microphone here for you, Greg.
It's not really in-depth. Hello? It's not really in-depth, but I noticed when I was looking at it, and it is great, thank you for such a good document, there's a search tool at the top that you didn't touch on. You can, at least I found that on the version that Jean had on her tablet.
Which one?
It's just a little search, like a looking glass that you see for searches. And I was able to type in the word Medicaid, and then I could go down. There were 32 references to Medicaid, a real easy way to navigate on a specific subject.
Oh, yeah, this one. Yeah. Okay, yeah.
So that's a good tool, and I
Yeah.
just thought you might want to share that.
Excellent, thank you. That's very helpful.
Okay, I have a question for Dr. Burkholder. Is this on, I think? Sorry. You mentioned that, and I guess I don't know that I realized this, that any epileptologist needs to be trained in Fintepla in order to prescribe it. And so is that common knowledge among all the epileptologists, especially the adult epileptologists? And
That's a good question. I'd say that it is probably a mixed answer. It's definitely common knowledge, of course, among pediatric epileptologists. With adult epileptologists, and take this with a grain of salt, I'm speaking what I expect experience to be, but I don't necessarily know. In circumstances where adult epileptologists work in close concert with pediatric epileptologists within a single practice, then those adult epileptologists are probably very aware of it. If it's just an adult epilepsy practice, because those are out there, they exist in the world, and that's perfectly fine. But if it is an isolated kind of island of adult epilepsy practice, they actually might not be aware. They'd be aware of the drug probably, but not necessarily of the process. And so that's very important to be aware of. Because again, it's very simple to do, but if, it doesn't matter how simple something is, if you don't know you need to do it, then you figure it out in the wrong way. But I'd say they will be aware of the drug, but they might not be aware of the process. Okay. Is the simple answer.
Okay. And then I just wanted to add one more thing that the two parents said, which I don't know if this is helpful for people, but just one thing I found with the transition for our daughter from a pediatrician to an adult. So if you can't decide who to go to or whatever, many of these records now are electronic, and so they can, so if you're a primary care provider, your new one can access the pediatric information, and you're not sure who to pick. I guess if it were me, I would lean towards somebody where they already have access to all these medical records, as opposed to using the information that we have. So just thought I'd say that.
I'll throw a name out there, and this isn't necessarily a plug, but Epic is the most common EMR out there, and it is very handy for sharing records between practices that are unrelated to each other.
Okay. Thank you. Yes. Hi.
Hi. I was wondering if maybe at CHARP, given what we're learning about the Parkinsonian symptoms showing up, if you ever recommend adding new providers that we haven't seen before, like movement disorder specialists, and whether we should be looking into, my daughter's 19, and I can see the beginnings of some of these things. So I'm wondering, should I be trying to get ahead of that? Maybe revisiting PT that, we were aggressive with when she was younger, but as the years have gone on, we're not doing PT, and she used to wear AFOs until we're done with those, and so maybe we should be revisiting orthotics, and so maybe not just transitioning to the same providers we've already had, but maybe looking into other providers.
That's a fair point. There's a lot, obviously, that's still yet to be known about Parkinsonism and other mobility impairments related to Dravet and why they happen. Not to get too in the weeds, of course, with typical Parkinson's disease, it's a lack of dopamine-producing cells. But when you're thinking about a disease that's based off of a mutation to sodium channels in the vast majority of people, then you'd have to presume that, well, the dopamine-containing cells are there. They're not dying off. It's some other process, potentially. So right now, we're still translating what we know about Parkinson's disease and other forms of Parkinsonism and how we treat those, and kind of extrapolating that and transitioning it to Dravet, although in the future, hopefully what we find is something that is more effective and more disease-specific, but it might not be related to a dopamine hypothesis specifically. In any case, that aside, what we do know about Parkinsonism is that there is definitely use it or lose it, right? So it's a lot easier to maintain what you've got than regain what you've lost. So even in people who have mild forms or mild degrees of Parkinsonism, with Dravet or with other disorders, but with Dravet, I think physical and occupational therapy is still useful, right? Because it's simple movement, right? It's keeping up that simple movement and making sure that stamina is good, and really doing what you can to keep what am I looking for here? Keep somebody capable, right? To maintain what they've got. So absolutely. And that may not be necessary for everybody, or might not be necessarily immediately upon transition, but later on. But in that case, then movement disorder specialists can come into play, and especially as information on that evolves and those treatments evolve, then that may be something where, as a specialty, they're getting more involved anyway, and it's not necessarily the epileptologist that's calling those shots. As far as when, that's up in the air, right?
Yeah, I was just wondering if even at CHOP, do you have movement disorder specialists, and have you ever roped them into the Dravet world?
That I don't know. There are not that many pediatric movement disorder specialists. I'll say I'm an adult epileptologist, so what I know about the pediatric movement disorders world is limited. But I do know. Oh, I see. I'd say it's a reasonable consideration, depending on what's going on and what they're seeing on there. Because Parkinsonism, with the exception of Dravet syndrome and rare juvenile cases, it's an adult disease, right? Adult neurologists recognize Parkinsonism pretty easily. I don't know how pediatric neurologists feel about it. I know there are movement specialists that deal with that in juvenile forms of Parkinson's and management of that, but they tend to be pretty limited. So I can't speak for CHOP or how anybody feels about that, but I think it's a reasonable consideration.
Any other questions? I actually have let's go in the back.
Sorry if I missed this at the start, but where is this available, the electronic form?
So it will be available on the Dravet Syndrome website. It'll also be available at viprarecare.com. And I think, Marianne, will there be a follow-up to kind of send a link out? So there'll be a communication follow-up in the newsletter, I think you said, or something. Yes, exactly. Yes, so we're waiting for a website to be finished being developed, but it'll be very soon, hopefully by the end of June. Yep. And any other questions? I think about your questions, and then I actually had a question because between the questions that we just heard. So what happens if like half of your providers are pediatric providers and there are also adult providers? Are the adult providers going to work with the pediatric providers? Like, how does that work? Does that pose any issues?
Like if some pediatric providers are staying on and others are signing off and,
Yeah.
and transitioning.
So what is that?
You
So
know,
you mentioned that too, I
yeah,
think.
any individual provider is going to end up having to make that decision for themselves. I can tell you from my standpoint, and I think most of us would probably feel this way, that as much as possible, we'd work with who you're seeing, right? If it's in system, it's a lot easier than if it's out of system, but either way, I think everybody's open to trying to make things work and make sure that everybody gets the care they need.
Yeah. So I'm kind of curious in the room, how many people are in transition or have completed? Wow, that's impressive. How many people haven't started and are behind? Okay, a little bit? Yeah. Well, keep at it. Keep at it, and there are a lot of resources for you. So are there any other questions for our panel for this section? Yes, please.
For this part of the presentation or not. I am wondering about hospital stays, because right now we stay with our son when he's in the hospital 24 hours a day. How do we manage when it's not a children's hospital, but a regular hospital?
I just know that that's my big issue with one of the questions, because I'm used to being with my daughter almost the entire time, and she doesn't speak very well. She's functionally nonverbal, and I brought that up with the team that I met with, and they're saying, well, one person said, the most recent appointment that I had said, well, over the years they're going to start to learn about how Andrea is, and there'll be nurses that know her, but right now I'm like, yeah, I plan on keeping and plan to advocate to stay with my daughter, because I know what she's like, I know what she means, and if they're all new nurses, I'm in for a fight if it comes to that.
And that really comes down to individual hospital policy rather than a pediatric or adult schism. I can tell you at our hospital, anybody can have overnight guests, doesn't matter what age they are. And in fact, we'd prefer it when the patient can't advocate for themselves, right? That's important. I don't think anybody would argue against that. So I think that's probably something that will end up being okay. It's possible that an adult hospital or adult area of a hospital may have a policy where they don't allow overnight guests, but I would imagine that they would uniformly probably have exceptions to that for those specific reasons. Because nobody, no nursing staff, no physician staff, nobody wants to be in a position where they're having to make decisions for somebody who can't make decisions for themselves, and the caregiver's not there, and you can't get a hold of a parent, or it's just, there's no reason that somebody shouldn't be able to stay to fill that role, right? It'll just come down to individual policy for the hospital.
Hello. If I could just make a comment. I'm not from the States, but in Canada, when we did our transition from peds to adult hospital, my daughter needed a VNS replacement. The battery needed replacing, and if I could just make a suggestion to you all, is do your homework before the appointment time. We spoke with the surgeon. Our neurologist knew what was going on. There was no way I was going to leave my daughter. In fact, I stayed with my daughter all the way until she was unconscious in the operating room. And there was one nurse that approached while my daughter was in prep and said, "Okay, we're ready to go." And I said, "No, you're not. We're not taking her." And she was adamant, and I said, you know what, the surgery is off, like, so you can let them know that we're not moving forward with this. And we had spent all morning there waiting to go like right into the surgery. And then the surgeon came out, the anesthesiologist came out, no problem, ma'am. And I had done my homework, but this particular nurse, I don't know, didn't read the memo. And I followed up afterwards. I got her name. I did the whole thing. They followed me around afterwards. We went into recovery with her, which is not normally allowed. And we just did the whole thing. I just did the whole thing with her. And I just made it clear from the beginning how it was going to be, because I was always there with her. So I'm with you, Mom. Like, you just advocate. And again, I'm not from the States, but I'm sure every hospital wants the best care for their patients. So if you do your homework, they should follow up.
I just want to reiterate that my daughter just went under anesthesia about 3 weeks ago. And even though the hospital is a pediatric hospital on half, the other half is adult. And everything was done on the adult side, except for one of the physicians, but they still let me go in with her in every room, anesthesia everywhere through. They wanted to make sure. And once they were in surgery, they treated me because they're like, I was the only one that knew how to communicate with her. I know her, I speak Abigailese. So just like the rest of us, they don't speak it, and they were really accommodating for that.
Can you hear me? Okay. Just a small suggestion as well. When you go to an adult hospital, as a parent, you need to pack a bag of things the kids, your children, adult children like, because they won't have everything, the special Band-Aids and the stickers and all the fun things necessarily on hand. And so just bring those things along, and they're very happy to share those things, but they won't necessarily have them. So that's one thing.
Bring your medications too, which you probably already do to the pediatric hospital as well. But I can tell you, if you are physically changing hospitals, in our hospital, our pediatric hospital is within the entire larger hospital, so it's a shared pharmacy. But if you are physically changing hospitals from what you're used to, take your medications with you, because some of this stuff they might not have, right? But they can give from your own supply as long as you let them know that they have it and they are there to give it and document it and chart it, right?
Well, thank you all for that really great discussion. Let's give a round of applause for our wonderful panelists. Thank you so much. So we're going to move into our next session in the workshop, which is preparing for early adulthood. And we're going to get a fresh group of panelists up here to share their experiences. We're going to go through this section, and then we're going to give you a break. So thanks for hanging in there with us. Come on up. So for this section, preparing for early adulthood, I wanted to highlight a few pages from the C.A.R.E binder that you may find helpful and that are relevant to this particular discussion. So I'm going to refer you back again to the C.A.R.E guide, because that is kind of our North Star as we navigate everything. Going back to the checklist, as I had mentioned previously, not only are you going to find the items in there that are specific to medical transition that we just discussed, you're going to find a number of items in there as your child prepares for young adulthood that are going to be really important for you to look at. So looking at pages specifically like 9 and 10, 12, 15, and 16. So I just mentioned that. I don't know if you want to jot that down, but those are going to be some pages that are going to be really helpful for preparing for early adulthood. I also want to highlight the legal checklist. So from the long-term planning section, the legal checklist, making sure that you have all these documents, and not only that you have them, but you have them organized in one place, and that the people who will be providing additional support for your child knows where to find this information. And then also the day programs, you want to document that as well. That is on page 53. You want to make sure you have that information prepared. And then another section, which I had mentioned earlier, this daily living section, this is going to be really key to ensuring that you have all of your records organized and that you have laid out a beautiful foundation. You guys work really, really hard to provide amazing care for your loved ones. And so we want to do everything we can to keep that care consistent, no matter who is providing care for your child, whether it may be another family member, an adult sibling, or if they're living in a residential home. Whoever is taking care of your child, let's do the best we can to provide them with all the information they need to step in your shoes. So I hope those sections will help you as you look at this section. And now we're going to go ahead and start with our wonderful panelists. So we have Shannon, Brenda, and Kathy. We're going to start with Shannon to talk about guardianship and SSI.
Hello. Good, it's on. So my daughter just turned 19 a couple of weeks ago, so we're kind of in this beginning phase of all of this, and I know there's a lot of you in this room that are way ahead of our family in terms of this journey. I'm just curious, who in the room has not gone through the process of applying for guardianship or SSI yet? Okay, that's kind of about what I was thinking, probably close to half. So some of this is state specific and some of it isn't, but the overall process is pretty much the same. We live in Georgia, and so the way guardianship works in Georgia is that it is a standard form for anyone that lives in our state, but the actual process goes through your local county court system. So what everyone has to do is the same, but where you submit it, the amount of time it may take, and the steps they go through legally to get you there may be a little different. So the biggest piece of advice I have is always, with everything in our world, find somebody else who has done it before. And in my case, the guardianship process was made so much simpler. I heard all these people talking about hiring an attorney, and when I started going and looking, like they're charging $3,000 to $4,000 to submit the guardianship paperwork. And I downloaded the form and I looked at it and I thought, you know, there's some things on here that I don't quite know how to answer to make sure that we get this set up the way that we want, but I think I can figure it out. And so I found a local organization that's affiliated with Parent to Parent, and they had a webinar recorded that was an hour long on their website where a lawyer, well, they had two actually, one that just explains the process and this is what you need to do, and another one where the lawyer literally walked through the form line by line and explained what to put on that form. And I have one of Elena's friends, was turning 18 around the same time. His mom and I both said, we're gonna watch this video. We watched it, we started filling out our forms on our own. We got what we thought was the right thing. We met up for lunch one day. We brought our laptops and we went through it together to make sure that our understanding was the same. We literally went to the courthouse together to drop them off. My husband joked about, I hope they don't mess up the paperwork and we get Alex and they get Elena. But it really was not that complicated of a process as long as you understand the right way to answer. And one of the things that's frustrating is that there are so many things on this form that really don't apply to our kids, because it's the same form that is being used for someone who is applying for guardianship to take care of their elderly parent, or a sibling that maybe can no longer make decisions for themselves. And so there was a lot of the process that you're kind of like, why do I have to do this? Why do I have to send a letter to two people to tell them that I'm taking guardianship of my intellectually disabled child when everybody around us knows that she can't make decisions for herself. But it really, the process is to protect those people where someone may be trying to take guardianship of someone that they shouldn't. So a lot of it really feels like overkill, but it was not that difficult. My piece of advice would be to start the process well in advance. I know at least in Georgia, you cannot file the paperwork until within 6 months of their 18th birthday. We actually kind of got a little behind and we didn't do it until about 3 months. We got through the process pretty quickly, but you don't want to wait too long because heaven forbid something happened to your child the day after they turn 18 and you end up in the hospital. I like to think that, most doctors would be like Dr. Burkholder and be reasonable and acknowledge, okay, clearly this child cannot make decisions, but legally you cannot sign on behalf of them once they turn 18 for anything, whether it's school or medical care or anything, unless you've got that official guardianship. So another piece of advice I learned from others was in deciding who to make the guardian. Like at this point, it's just me. We chose to have it be only me and not my husband also. Not that we aren't equal partners in this decision, but there was the concern that there could be a situation where you have someone that says, no, I need both of you because you're both listed on this paperwork. You can't make the decision without your husband agreeing to it also. And so for that reason, I think people do it both ways, right? But we just decided to make it that way. And then we have it set up, we haven't done it yet, that in my will that it would specifically state that if something happened to me, then it would transfer to him. And he'd still have to go through the court system to get it done. But we went with that approach rather than having it be both of us together. And I know from talking to other parents, especially if the child's parents are divorced, that it would probably be better to have just the primary caregiver on the form, on the guardianship application, because they're the one that is physically with the child. So the last thing you want is your child to be in the hospital and the other parent lives in another state and is not physically present and they're not there to speak on behalf of the child. So those are some of the things that I learned about the process. And like I said, really seek out the resources in your state that can help you through that process. If you decide to pay a lawyer because you don't want to deal with it, by all means do that, but don't feel like you have to when there are people out there that can help you figure out how to do it yourself. We also applied for SSI, and the biggest thing about the timing for that is that you cannot do it until at least the first day, the month after their 18th birthday. So Elena's birthday was June 3rd. I had to wait until at least July 1st to apply, and the reason for that is because if it's in the same month, then the parent's income gets considered. I guess it must be like a rolling month kind of thing. So we waited until early July and applied. It's another form that you have to fill out and submit a lot of paperwork and things. I've heard in Georgia especially it can take a year or longer. I'm sure it's like that in a lot of states. We were really fortunate. We got it approved in about 2 months. And some of my friends that filed around the same time are still waiting. And I really think a lot of the credit to that goes to DSF and some people within our community that fought really hard to get Dravet syndrome listed on, there's a compassionate allowance list for Social Security. And because Dravet syndrome is listed on that list, it kind of fast tracks us. In fact, we had an appointment scheduled for a neuropsych eval that was a part of it. They were sending us to like the state appointed doctor to do the testing, and I got a call the next day that said, never mind, you don't have to go. And I really have a feeling that it was because once somebody went in and reviewed it, they said, oh, you know what, based on everything that the parent is saying about the child and all the records and that compassionate allowance list, I think that's what allowed us to get through the process a lot faster. And one positive, my daughter did not previously have Medicaid. We had never applied just because we had pretty good private insurance. And the Katie Beckett paperwork is so burdensome and it's so difficult. So as long as we had good coverage, we didn't worry about it. I was absolutely shocked when I got the letter approving for SSI in the mail, and literally the next day I got a Georgia Medicaid card in the mail. And I was blown away that like something was easy. I didn't have to ask for it. So one positive of getting through that process was that suddenly we have Medicaid as a secondary, and we've already been able to take advantage of that.
That's amazing. Thank you for sharing, Shannon. I wanted to just highlight, and I was trying to find it, and I will find it where it is in the care binder, but what you mentioned about that, the compassionate list. So there is a link in the care guide that will take you to a website so you can check for your individual state to see if Dravet is listed. So I will find that while we go to the next person so that you can know where to find that information.
The compassionate allowance thing, it's a federal thing, so that would apply to everybody regardless, since Medicaid is a federal, it may be administered by your state, but it's a federal program, so it would be.
Okay, excellent. Thank you so much. And Brenda, over to you.
Hi, I'm Brenda Farrell. My son Brian is 31. We went through this when he was 18 in Tennessee, and the one thing I would add to Shannon's comments about guardianship, in Tennessee we had to get guardianship first, and then after he was 18, it transferred and we had to go back and get it into conservatorship. And so check that with your state because it varies from state to state. The other thing I would suggest is that you make sure you have a copy of that guardianship conservatorship letter with you at all times. Be sure to give it to all of your medical doctors, your insurance. They won't talk to you sometimes if they don't have a copy of it. So I keep one in my purse, like when we have to go to a hospital in a different state or city or whatever. I'm supposed to talk about day programs. My son was fortunate when he was in high school the last 2 years. He was able to go half a day to a day program at Sunshine Industries in Knoxville, Tennessee. And that's a sheltered workshop. He worked on the work floor stuffing makeup brushes into Ziploc bags, putting labels on them, labeling envelopes. This job I thought could have been the most boring job in the world, was checking to see if hangers were recyclable or not. He had to lay the hanger down on a piece of cardboard, and if it laid flat, it went here. If it didn't, it went there. And can you imagine doing that 8 hours a day? Oh. Well, he did well in that for not really well, but for 6 years. And then they got a new program and they said, we think Brian needs to go off the work floor. He's not staying in his work area. He's not staying focused. He wants to visit with everybody else. He's spending half the day in the bathroom to avoid working. And he's not motivated by the more that he works, the more money he's going to get paid. He loved the paycheck, but it didn't register that you got to do so many items to get more money. They started then a day program where they were in classroom learning different things about how to be a good worker and fill out applications and all that kind of stuff, interview. Well, after 4 years of doing that with the same group of people, they changed now and it's a community participation program. So 2 days a week, they go out and do volunteer work for Meals on Wheels. They also volunteer at Goodwill and at C.A.R.E, which is similar to Goodwill where we live. They go to the park. The Parks and Rec does a lot of recreation activities with them. They go to the pool 1 morning a week. They go shopping. They have snacks in the break room. And so not the whole group, but they go out in groups of 3 to 4 with a staff member. They go to Sam's and buy the Cokes and the snacks to put in the cooler in the break room, and then they practice selling them to each other. He was going 5 days a week, which was wonderful. I loved it. And in December, we had a meeting because his behaviors were not as good as they should be. And now he's just down to a day and a half a week. He wanders off from the group because of that lack of impulse control. If he sees a dog or a firefighter or hears an ambulance, he'll run off and get in trouble. So I'm praying that he doesn't get kicked out. If your city has a Sertoma group, we have a Sertoma Center, which also does day programs. The Cerebral Palsy Center has a day program. Check with the ARC, A-R-C, in your state or city. It stands for Association of Retarded Citizens, which is a bad word we don't use anymore. So it's just called the ARC. And they will have information for you. Check with your local Epilepsy Foundation and also the Autism Society. Our Autism Society in Knoxville bought a group of homes, and they have group homes for people with autism. Then there were people in Blount County, right next to Knox County, and the parents got together and started a day program 2 days a week. It's called Bloom. And the adults plant their own gardens and then sell their produce. But many of these programs are parent-based. I want to mention a few activities that Brian does. He loves doing therapeutic horseback riding, where he gets speech, OT, and PT in a fun environment. He does Special Olympics, swimming, bowling, basketball, track. There's also TOPS soccer, which is for people with special needs. Challenger Sports. Challenger Sports, where We Are, does softball, golf, swimming, bowling, and basketball. Now, not all Challenger programs will do that, but look it up. Your local YMCA may have special programs or offer special rates for a membership for a person with disabilities. And then adaptive sports. Look up Move United or DSUSA. Brian participates in snowboarding at Beach Mountain, North Carolina every January. He can't snowboard by himself, but it's really cool. They clip a hook on the front of his snowboard and have tethers that go around him, and his instructor skis behind him and then can control how fast he goes down the mountain and his direction. So keep those things in mind. And one of the last things I'd like to mention is the Tim Tebow Night to Shine, if you don't know about that. It happens either the first or second week in February every year across the United States, usually put on by churches, and it's a prom for teenagers and adults with disabilities. So just want to encourage you to pursue some of those activities for your children.
Excellent. Thank you, Brenda. Can I just ask a really quick question? Did you have to go on a wait list for any of those programs? Because I know that's something that a lot of people, I think, have struggled with, trying to get into day programs, making sure you get on a wait list.
I didn't have to go on a wait list for those programs with Brian because we had started as in high school.
Okay.
And then it just transferred over. But do begin looking into day programs where you are early because they fill up, because there's just not that much out there for adults with disabilities.
Okay. Yeah, thank you. Thank you, Kath. Thank you, Brenda. And over to you, Kathy. Yeah.
Hi, my name is Kathy Dodd. I'm the mom to Stacy Dodd, who is 25 now. She'll be turning 26 next week. She was diagnosed with Dravet syndrome in 2007, so she was 9 years old at the time. And she's currently experiencing, I just thought I'd give you an overview. She's currently experiencing seizures about once every 2 to 3 weeks. So. And I'm going to talk a little bit about daily living and things like that, and just our experience, and a little bit about Stacy's programming. But I want to add on to both what Shannon and Brenda have talked about just briefly. So my husband Bob and I actually are joint guardians for Stacy. We had the same decision point of what to do, so I think that's a personal choice for each of you. I just thought I'd share that. And I think part of that is because we both are at times taking Stacy to different doctors. So my husband Bob often takes her to the dentist or whatever. And I can't say more than what Brenda said about you have to have a copy of guardianship with you at all times. I actually happen to have it just on my phone, filed in a little note. I swear for some providers, I give them the guardianship form every single time I'm there. I'm not quite sure. Even on Epic, I'm not sure why it's not on Epic. I get asked that question all the time. I'm like, I know it should be on there. So, and the other thing that Brenda talked about was just day programming, and I'll talk about this in daily living, but I can't encourage you all more than to start thinking about programming outside of school as early as you can. And I would say, my biggest learning was Stacy happened to have turned, and we live in the state of Illinois, so we live in the Chicago area. So you're eligible for school services until the age of 22, and then you age out. And unfortunately for her, that was right in the middle of the pandemic. So that was very challenging for us. And the schools are the ones that really should help you with the transitioning. to, whatever programming that will look like. And because they couldn't help Stacy's, it was just harder for her to transition, meaning she couldn't go to some of the day programs as often as we wanted to. And so really, the schools, that's their role. Their role when you're in a transition program is to help you transition to a new program. And if they're not doing that, you need to be talking to the schools because that's really their primary role. So I was going to talk just briefly about daily living, and I thought it might be helpful if you could just bring up like that one little checklist. I think it's like, where is that? Okay, it's like the first, thank you. Okay.
You are welcome.
I'm not going to touch on all of these, but I thought I'd just touch on a few of these in terms of things to think about. We talked a lot about transitioning to a day program, but there's a lot of other things to be thinking about in terms of daily living as you're thinking about getting your child ready for any sort of adult services. And the things that I think are important to be thinking about are bathing and personal hygiene, obviously day programs, but dressing, sleeping arrangements and bedtime routines, and toileting. And the reason why I bring up those four is in terms of like toileting, bathing, I would say I should have added feeding and nutritional needs. If your child, for example, can't go to the bathroom on their own, that will be limiting to programs that are available to you. And so, the reason why I bring those up is because your schools can help them with toileting, and they should be. And like when Stacy was in high school, we had them giving Stacy a shower almost every day so that she could become more independent on showering. And we had them teaching her some basic things around feeding and how to, and so those are just, I know those seem like really simple things, but they're really important. Many of these day programs simply do not support one-on-one, they don't have one-on-one support the way they have in the schools. I mean, the schools are required to provide the care that they need for every single student who can go to that school. The day programs are just not. And especially today with all the issues we have with staffing and caregiver support, it's even harder to get your child into some of these day programs. And I can appreciate what Brenda's saying about behavioral issues. And so I think many of our young ones, adults, have problems with transitioning. That's like the, going from one activity to the other, or just not going to the second activity. Because they just won't. And, we had Stacy she goes to a day program in our community, and we've noticed that over the last year or two, they've kind of backed away from some of the programming that she can do because they say, they'll take her to, out for lunch, but then after lunch, they want to go to the library, and she won't go to the library. And so, then she's holding everybody back. So, anyways, so those are things that are really great for your school to be focusing on. And then I thought I'd just end with kind of, I thought you did a really nice job, Brenda, kind of sharing your schedule for your child. So I thought I'd just share a little bit about Stacy's schedule. So she goes to a day program in our community 4 days a week. When we're very lucky, it's literally very, very close to us. It's also a community-based program. So the things that they do there, now she's not able to really do some of the volunteering and working jobs just because she would prefer not to because she's too social. But they still do things like they go to a fitness center 2 days a week and work out. So they go out for that. They go out for their meals and things like that. They do like kitchen and help with having them learn to cook or do those things. They do setting the table, all those kinds of things. So a community day program I think is really great for many of our Dravet kids because they like to be out, they like to be doing things, and so she does that 4 days a week. She then goes to a day program. Our long-term plan for Stacy, or hopefully becoming more of a short-term plan, is for her to move into a residential living facility, and so she's going to a day program there 1 day a week. And then she's actually, after the program is over, she's going to the house that she is potentially going to live in. And sorry, I'm watching her walk out, and I was just making sure she wasn't walking up this way, because she has tendency to do that. So I lost my train of thought. Oh, so she goes there to this, it's the place where we're hoping she'll live. And then after the day program, she's actually going to the house and having dinner and doing an activity with them. And so we're trying to just kind of gradually get her assimilated there. I think it's also really, really nice for the staff to get to know her, and especially the staff in the house that she'll potentially live in. And then other things she does, I do think all of our Dravet kids like to be busy for the most part, and keeping them busy once they are out of a school setting is really challenging. It can be. So she does horseback riding. She loves horseback riding. She does a choir. She likes to sing, so she does a choir. And then we use our special rec. We have a what's called a North Suburban Special Rec Association, probably similar to something you mentioned. I don't know what yours might be called, Brenda. But so it's like a, it's intended to provide recreational activities for your kids. And so Stacy does a Friday night social, but they do lots of other programs. So you could do Special Olympics through them, you could do basketball, you could do swimming, bowling. They actually also do have like day programming, one day a week or whatever. And the thing that those programs, especially the special rec programs, we had Stacy starting in those when she was like in 5th grade. And so, again, the staff then know her. There's some consistency. Even if you don't do many, just do some. And even if it's not one that you like, then try another one. I would say when your child is in high school, all you're trying to do is get them, I shouldn't say all, you've got lots of things on this daily living, but what you're really trying to do is get them into other programs, get them comfortable going to other things, get other people comfortable working with them. And, I mentioned this about some of the dressing and the bathing and things like that. Take advantage of your school and the things that they will do to help you transition. Like, it was like a godsend that they were giving Stacy a shower every day for me. And that they were helping teach her, and it was helping me with end of night routine can be very difficult. So hope I didn't talk too long.
Yeah, no, that was perfect. Thank you so much for sharing, Kathy. Yeah, of course you can.
When Kathy was talking about the bathing, I just want to share a friend of mine. Her brother had lived his whole life with the mother. He's special needs. When the mother passed away, the sister was left in the lurch. They did not have a residential program set up for him, and all of a sudden it was an emergency situation. Well, they were able to get him into a residential home, and the staff said, "Here, go take a shower," and he would just stand there and cry. And she asked her brother, "Why are you crying?" And he said, "I don't know what to do." He got in the shower and had no idea how to bathe himself. So don't let your children grow up without knowing how to take care of themselves, because if something happens to you, then who's going to take care of that for them?
I just want to say one more thing, too. I don't know why this is the case with the day program and places we're going to, but in addition to like toileting, them eating, if they don't like the food there, for whatever reason, the day programmings are really, they think that that's a problem. So I think some of our kids like the same food every single day. Stacy likes salami, cheese, chips, and she has not eaten that much even here during this whole conference. But that can be a problem for these programs because they generally are making a meal for everybody, and they want everybody to eat that meal together. They don't really want each individual bringing their own meal, because then the others want to bring their own meal, and it just becomes a problem. And so just think about that as well.
Thank you so much to our 3 panelists for sharing all their experiences. So we have about 10 minutes for questions. So if anybody has a question, please raise your hand. And there was just one thing I wanted to clarify with the compassionate list. There is actually a link the C.A.R.E binder, and it's because this C.A.R.E binder was created for the broader rare epilepsy community. So you know, LGS or other rare epilepsies, they'll be able to check that list. So I knew that was in my head, and I couldn't figure out why. All right, well, what questions do we have for these wonderful panelists? Anyone? They did cover it all. Oh, we do have something over here.
Yes. On. Yeah, I just have a couple of comments because Shannon, when we applied for SSI, so I don't know, I would thought that was sort of the same across the country, but maybe there is differences. You can apply the month that they will, within 30 days of them turning 18. Even like Alexis's birthday is January 3rd, so her benefits could not start January 1st, because if any days they are living with you, you get nothing for that month. So your benefit won't start till the 1st of the next month, but you can apply before that. And then just guardianship, I think, is... Oh, go ahead, sorry.
I think my understanding is that you can't actually apply until the first day of the next month, so that the parent's income doesn't include it, but they will, once you get approved, they will back pay to the date that you applied.
Yeah, well, we were told we could apply. Don't apply if you applied before 30 days. So if I did it December 3rd, then no, they wouldn't count. But we were able to apply in December, and then her benefits started February 1st. So I don't know. I guess we can,
Yeah, my understanding was that everybody told me, and what I read too was that it'll just get denied. If you apply before the next month, it gets denied because then your income is included, and they need to And another point about that too, with I think the federal dollar amount is around $900 a month that you can get, but if your child lives with you, you don't get that full amount. You get like 2/3 of it. And I know that people, like if you submit a rental agreement and show that your child is paying you rent, then you can get the full amount. And I actually was about to do that, but at least in Georgia, I've seen a lot of people lately talking about how they're getting stricter about that, and they've been getting denied for doing that. So that's something to keep in mind, that as long as they're living with you, you don't get the full amount.
Yeah, well, she did. I mean, we applied in December. She got her benefits, and we were able to charge her rent, but it was up there. There was a certain amount, but then we went through the process of a certified family home, and so now we can almost use her entire check as rent. And then I know, like with Guardian, that definitely changes. And I remember hearing about, there's some states, it's not even states, it can change like county to county, where you can do what you did, fill out a form and take it down. But in Idaho, you cannot do that. And we did have to pay thousands for lawyers, because she actually has to have her own lawyer, which we have to pay for. and then we have a court date where her lawyer's there and we're there, and it was fun and straightforward, but we did not have the option to just take it down ourselves and do it. So that I know is different within each state. It can be really different too. And then we did co-guardianship, but that doesn't mean that both parents have to sign off on things. It's sort of written in a way that you're co-guardians, but each person can, kind of work on their own.
And that may be something that depends a little bit on the provider, what the situation is too, whether they would require both of you to do it.
I just want to add that about the guardianship, that's very state specific. Because there is a national, I can't think of the exact word it is, but there's a binding agreement between a lot of states, a reciprocal law of like certain states will accept certain guardianships, but like Florida accepts no one's guardianship. And I mean no one. And another court from another state, doesn't matter. So it's very state specific on that, and the laws on that, because and co-guardians are kind of a different situation in Florida. So look also into your local bar. You can usually get a free advice also. or like a $50 charge through your local bar. And another thing I want to add about the guardianship papers, make sure you carry one with an official stamp on it, not just a photocopy, because hospitals will say, it's not legal, it's not your legal document, it's a photocopy. We don't take it. And I luckily had one. I keep one in my car besides with her at all times. But I learned that lesson the hard way.
Wow, thank you so much. I think we have time for one more quick question.
Thank you so much for sharing your experience and the insights, and it was really enlightening, and I'm wholeheartedly convinced that my daughter will be kicked out of any day program that we ever try to put her in. I can't even imagine that this would ever work for her. But my question is, when your child goes into a group living situation, this might be like for the whole group here, is day programming then out of the question and they just stay at this residential center all day? And does that residential place okay, so like even if they're not living with you, they still have the option, if they don't get kicked out or whatever, to go to like programming during the day and then they just go back to their residential living?
Is this on? Yeah. I mean, I would say most residential living arrangements have their own day programming as part of it. So, and so that's why, like Stacy today is going to the day program at the organization. We think she's going to move into a place called Misericordia. So that's why she's going to that day program. However, we expect as she first moves in, that she's actually going to also go to she has two basically day programs, and we expect that for, at least at the beginning, she's going to go to her other day program, that they will transport her, they will take her from her living arrangement to the other day program. And many of at least the residential programs that I've been experienced, they will allow these individuals at least temporarily to go to their other day program to help with the transition. But like I said, most residential living arrangements have a day program or a community-based program or all different kinds of programming to support the residents who are living there.
Thank you.
Okay, well, thank you so much. Really appreciate it. Let's give a round of applause for our amazing caregivers. So we're going to take a really short break, 10 minutes. There are snacks outside. When we come back, we're going to be talking about later adulthood, and we're going to have two amazing caregivers on the panel, as well as two adult siblings to share their experiences. So please come back, 10 minutes. We'll see you soon. Thanks. Welcome back. We're excited to continue this conversation. We're talking about the C.A.R.E binder, which is a new resource caring for adults with rare epilepsy. And we are in our third and final session for this group, which is going to be discussing preparing for adulthood. We have four amazing panelists with us today, two caregivers and two adult siblings. So I want to just call out, there are a couple of pages that I want to bring to your attention that might be helpful and relevant to this particular discussion. Of course, I'm going to refer you back again to the C.A.R.E guide, your little roadmap to get through this resource. The specific pages that you might find helpful are on page 7, 9 through 11, 17, and 18. And then the other section that I want to bring your attention to is long-term residential living. So there's a document in here that will help you to prepare for the search, perhaps to find long-term residential living. Many people who have not gone through this process before may have questions about, what do I ask? What do I look for? And so there's a checklist in here of things that you kind of want to observe. Some of it is just, what am I observing? And you can take this and, print it out, fill it out, take it with you as you tour different facilities to make sure that you're asking all the right questions, to make sure that the needs of your loved one are going to be met. So I encourage you to take a look at that section. And then the other section that you just want to look at in general, again, is this long-term planning section. So with that, we're going to jump right into our panel discussion. We're going to start with Greg. Greg is going to talk to us about his experience with residential care. So Greg, can I turn it over to you?
Thank you. I got to say, all this talk about guardianship. I have to admit, Jean and I were looking at each other because Danny's 43 and we don't have the guardianship yet, but we've always been able to sign as mother or father. Maybe we're just lucky, but I think it is getting cracked down on, so we'll be getting the guardianship soon. Anyway, I'm Greg Stock. My wife Jean here already told you about Danny, our son, 43. I am going to speak about this transition to residential care outside of our home. I have to say the Care Binder has a wealth of information, as Lori's been sharing. Pages 17 and 18 talk about housing, which is very informative. I think the way to plan this for your residential is to kind of step back and think about the big picture, where you are in life, because it varies by parent. So what I'm going to share is what happened to us, but depending on the child's needs, it will vary. So where do you begin? You need to get a strategic plan, again, thinking of the big picture. Based on our success in transitioning Danny to his home at age 25, so that was a number of years back, I'm going to share some of the things that contributed to that success and tell you a little more about it later. So there are probably three things in this strategic plan that helped us, and one was to become engaged with an organization that serves the IDD population. We have the C.A.R.E Tampa Bay, which is a very good organization. I went in to do my community service before Danny ever needed any kind of needs, and it was a good reputation for the organization. The C.A.R.E is what it is, and someone mentioned earlier what it used to stand for, but there's an C.A.R.E National, there are C.A.R.E agencies all around the country, and this has been really good for us. And 35 years ago, I signed up as a volunteer. I went on to the board. So I guess that's what I'm saying is one thing is to become very engaged in an organization that can start to make you familiar with resources, and in this case, especially residential, but really all the others too. Second point might be to start early. You can plan on moving into a new residence. A good time, and this is not just me, but there's a lot of wisdom at our C.A.R.E, which is very large. We have 18 group homes and daycare programs at several locations, is at about age 25. And I'll elaborate on that a little more later. And then after you get all that done, stay involved, stay with the organization. It'll keep you up with the status of your own child's group home, all the group homes, policies, you'll get to have input on that, and stay involved with your child. When we do that too, we see Danny twice a week, take him out to dinner, have him all day Sunday. So those are three things. Become engaged in the organization, start early, planning ahead for the age you're going to want to make the transition, and stay involved with your organization and child. So for Danny's, I was a general contractor, a commercial general contractor, and being on the board, they always wanted somebody to help them out with their construction of group homes. So I built several of them. This goes to some advantages to being in the organization. I've met so many good people there, one of whom was a pretty wealthy guy, and he said, "Greg, you need to build a group home for my son Mark." And he had bought a 2.5-acre site right across this bike trail that we live on. I said, "Sure, Carl, I'll do that." So we're designing this 5,000 square foot group home. Greg, some of the parents aren't ready. Well, he wanted to do it for his son and their kindergarten friends. They were all 19 and 20. Some of the parents aren't ready to let go of their kids. I said, "Well, if you want to consider Danny, I'll watch the home, Carl." This is just an example of what can happen. We don't know what's in the future, but yeah, have Danny be interviewed. Well, he has never known a harsh word in his life, so he got in. So we built it for Mark and Danny on one wing, 4 girls on the other. They sit down to dinner every night together. Our ARC has day programming. So that's the kind of thing being involved in an organization can yield for you. So I just encourage you to be involved in your community and with like-minded and like people that have like needs, because it'll help you kind of move forward in your goal. So we built the home, and I've been on the board ever since. So that goes to, we started early. Actually, 25 was hard to let go of Danny, but I've stayed involved with the organization. So in fact, I've been president 3 times in the 35 years. So, if you want to just break the ice, just volunteer initially to get familiar with the organization, then join the board of directors, serve on committees. That way you get to know people, like I got to know Carl. And then opportunities will come up based upon like life is. When you meet people, new things present themselves. The kind of knowledge you'll get by being on one of those boards, and this goes above and beyond residential, is resources like for funding, agencies that'll help support you, residential options, of course, that's what we're talking about now, day programming, legal, there's an attorney on the board, helped with guardianship, and he did our special needs trust, and advocacy. I think Shannon's touched on that a lot. So number 2, start early. The med waiver approval time can take a lot of time, varies by state. Sometimes it's automatic, like we've heard stories of that too. But the C.A.R.E binder, which has been reviewed a lot, has a lot of good pages on that. For Medicaid, pages 4 through 12. Everyone's encouraging you to use that, but it really is a great resource. And that's critical because it pays for housing, transportation, medical once you get on the Medicaid or med waiver. That always varies by state. And decide to make the change early enough to allow your child to adjust. So one scenario, and I've talked to other parents, it doesn't always apply, but just consider the risk if you pass away early, what's your child going to have to go through? They're going to lose their home, the place they've always been, and their parents. So even though this is difficult for us as parents, and it was for Jean and myself, it's worked out so well because now Danny, when he gets tired, he's ready to go home. And so when we pass, which we all are going to, Danny's going to be sad, but he's still comfortable. He's going to keep going to his day program. He's going to still have his life that he's always had. And brings me to the third one, stay involved with your organization, the home of your child. And so after they move in, establish a routine, because Danny sees us on Wednesdays from dinner on, and we keep him all day Sunday. So he still feels like he's a part of our home. But we just feel like that's a big part of our lives too. It also has freed us up to be able to go on vacations as parents. That wasn't our motivation, but so it really is a nice model if you kind of stick to those 3 points. Just get engaged with an organization, start to learn about the options, start early, and just stay involved once you get it all set in place. And I think as hard as it is at certain points, you'll be so satisfied when you get it all set up. That's about it for what I have.
Thank you so much, Greg. That sounds like a really smart strategy, and it worked out really well for you. So congratulations. I'm glad it's working. So Janice is going to talk to us about home care in the home. Over to you, Janice.
Hi, I'm Janice Stanley. My daughter's 26, and she currently is living with us. 2 years ago at the previous conference, I talked about a lot about residential placements and stuff, and I just want to play the devil's advocate here and tell you guys about some difficulties I've been having, and just, so you know what happens, not only in this, but in other areas, and also then I'll go to the care in the home. So, you know, there's a lot of reasons that you don't necessarily want or can have your child move into a residential program. A lot of residential programs have very long wait lists. A lot of day programs have very long wait lists. I've been a pretty good advocate, I think, for my children. I have 2 disabled children. And so I started really early. I think Emily was 3 years old, and I went around to the residential programs in the area, and I signed her up on waiting lists when she was 3. And I said, well, it doesn't mean I'm gonna put her somewhere. I just wanna know what's available and, you know, be prepared. And so, you know, when she was in her teens, I went back to some of those programs, made sure, is she still on the waiting list? Like, what do I need to do? What, you know, what's changed? And 2 of the programs had stopped taking in new patients or new clients, because what we were finding in a lot of residential programs in our area and probably across the country is that with better health care and better resources and more knowledge in all these different disabilities, these, thank goodness, these people are living much longer than they ever predicted. And so some of these residential programs have closed because they're turning into more of a nursing care facility for their current population, which is now aging. And, you know, they're dealing with Alzheimer's and dementia and all of the things that everyone else is also dealing with when they're aging. But they never really had those difficulties in the past because their life expectancies for all these diseases were lower. So this is great news that people are living longer, their health care is better, but it is also limiting resources in residential programs. Another difficulty that I have is day programs. Emily is in a fantastic day program. She would have never made it in the day program other than when she did, because she got in during COVID when there was an opening. I placed her on the list. I researched at least 15 day programs in my area, and most of them had requirements. They will not administer rescue meds at their programs. And so then you have to find a program that has a nurse or someone who will administer the medications. A lot of the programs have a nurse from 9 to 2 or 10 to 1, but the program runs 8 to 4 or whatever. And so they're basically providing a nurse to provide middle of the day meds for those people that take 3 doses a day. However, they don't have someone to administer medication during those off times. And so the best day programs and the best residential programs also have these huge waiting lists. And although you're on a waiting list, they also look at your client and say, will they be a good fit? And so if you have behavioral issues, if you have advanced medical issues, if you have these things that are not as easy to take care of, and then your waiting list is longer. So my son, who has Down syndrome, no behavioral issues, no medical issues, he'll get into a program, no problem. But my daughter, who has behavioral issues, medical issues, needs, rescue meds, it's very limiting. And so you can plan way in advance and you can, but the programs change, your child changes, and just keep these things in mind that going forward, no matter how well you plan, there's always obstacles to overcome. And so for Emily, we have her in a fantastic day program. We got her in during COVID. She had to go 30 days without a behavioral incident. On the 31st day, she whacked somebody over the head with a stick. I'm not kidding. But I'm like, hey, she made it in. She passed the deadline. And Emily has great behavior in a program once she's used to it, once she's there and is familiar and she's comfortable. She's never had a behavior plan in school. However, she's given me a concussion and a black eye, and she can be very aggressive. She can scream and fall down on the floor and throw a temper tantrum. And if that ever happened in one of her programs, she would be kicked out. And because they have long waiting lists, they don't have to keep a kid that's more difficult than someone else. So by the grace of God, she was able to get in this program, and she's really doing very, very well. And the longer she's been there now, the less and less behavioral issues she's having. And so, anyway, so that gets me to the point of life at home. Sometimes you don't have a choice, and you have to keep your child at home. And if you think you're isolated when they're in a school program, when you're home with you all day, every day, it is very isolating. It is very depressing. Their behavior increases because they have nowhere to go and nothing to do. And I feel for you all, because anyone who's going through it, you know, during her day programs, they have breaks, and those breaks are difficult. But at least she goes back, you know, they have a week off here and a week off there, and, you know, a few different things like that. And it's always difficult that Monday to get her back to going, even though it's just been a weekend. So those longer breaks really impact our population. I think, you know, it starts over getting them to go back and be comfortable. One of my suggestions is, I know several people whose children did not do well at transition at school. They weren't providing for them the way their high school program did. And they pulled them out, and they just sit at home. Well, we formed we were fortunate, some parents organized a group, so we get together every other Monday, we go to a farm. It's kind of a sad, I'll tell you really quick. It was founded by a mom who lost her child to SUDEP and one of the teachers in high school. Now my children are 4 years apart, and so my daughter knew her for 2 years, and my son had her in school for 2 years. And so it was her group of friends. And so we do this program, and it's unbelievable. They do events every other Monday. We go to a farm, we feed animals, we do all this stuff. But sometimes you just have to do those things as parents. You have to step up, and it's unfortunate with everything else on your plate. But otherwise, your kid will just be stuck at home. Special recreation programs. Again, they won't administer rescue meds at the special rec programs. So for every summer for Emily's life, I went to programs every summer and sat in a room so she could have the same experience and not have her mom there, but I was there to give her rescue meds. I think we need to really advocate for changes in those areas. The nasal sprays now, I mean, those are really pretty easy to administer, and the risks are lower, but it's all legal and it's all liability and those things. And so those are things that would really help everyone in our population if we looked into being able to get rescue meds so our kids can participate in life. Anyway, I wanted to make a few comments about things that were talked about earlier really quick, just in an effort to be helpful. So in our situation, we have a third guardian. And so in Illinois, you only need to have one person present. And so we actually have myself, my husband, and my eldest daughter. And we did that so if anything did happen to us, if we were in a car accident together or whatever, we'd have someone already as a guardian right there without having to go through that at that time. So if it's possible in your state to have guardian that's, you know, that can make those decisions, you can consider adding a sibling on if you want to. Another thing when they were talking about Social Security, a lot of people are not aware of the disabled adult child Social Security. Are people aware of that, or am I speaking, like, I don't want to, do you guys know what I'm talking about? Does anyone not know what I'm talking about? Okay, really quick, if your child is able to work, just look into the disabled adult child Social Security information, because if your child works more than like the poverty level, that could impact them receiving this benefit. And basically, when someone retires, an adult retires, the child is eligible for their Social Security amount. But if they are working and earning above poverty level, they would only be able to get their own earning Social Security. So it's just a complication in that law, but since they were talking about Social Security, I will just thought I'd mention that. And then The last thing is Emily has not transitioned yet into adult care. And I just wanted to mention the reason we haven't done it is we did the VNS surgery in September, and we wanted her to stay at Lurie Children's with Dr. Locks during this transition to the VNS treatment. And so when she gets regimented up to the, the dose, and she's been on it a little while, we will be transitioning. But there's all sorts of reasons to stay with your pediatric doctors. But I have found that even me with Dr. Locks, like who would ever want to leave Dr. Locks? She's like amazing. But I think we will be making that transition just because the rest of her care really is needed with adult physicians now. So I hope I've been helpful, and I didn't really talk too much about the care in the home because I think the care as an adult is similar to the care as a child, but like I said, a little more isolating than before because they're not even going off to school and they're not even, necessarily in a program, and so that's very difficult.
Thank you so much. Really appreciate you sharing all that, Janice. And now I'd like to turn this over to our two adult siblings, Murphy, who you probably remember him from the previous conference, who participated in a sibling panel, and who I will also mention is working with me to create a sibling companion guide for the care binder to help adult siblings, or it could be other extended family members too, right? To be able to take this information and understand and better able to implement it into daily life. So with that, I'm going to turn it over to Murphy to share his experiences and what future care looks like with his sister.
Hi guys, as she said, my name's Murphy Penwell. I'm 23 years old. I'm the youngest of three siblings. Grace is 26 and has Dravet, and then I have an older sibling as well named Annie. So there's three of us, and my parents are involved as well. Just kind of looking at what my sister's current state is. She currently is living in a facility that my parents it's a fourplex apartment complex that my parents transitioned from just a true, they rented out it and now into more of like an assisted living home. So there's seven girls in this complex or this apartment building, and they're able to have care from about 8 a.m. 8 a.m. to about 8:30 p.m. at night, and it's usually two care providers for the all seven of them. During the day, Grace goes to work at kind of. If you guys ever seen it like a bank or a convenience store where you drop $1 and take a bag of chips, that's kind of her business. She goes around town to about 10 locations and refills those, and so cleans up, just kind of helps out where she can. So it's a great way for her to get out of the living location that she's at and kind of get out into the world and be active more so than anything, and not sit on a couch, be on an iPad, sit in front of a TV like I'm sure we've all seen before. So it's a way for her to get out and just be active and productive outside of just sitting down and sitting on a couch all day. So I'm kind of in a role where I was not really involved in the true transition due to me being in school out of state and living out of state for work. And now I'm back in my hometown, and now I'm kind of more involved. I'm able to see what needs to be done, what new things need to be done, a new perspective to how that care is going to be moving forward in the future. We all have, every family guardianship situation is different. So currently it's under my parents. I know my oldest sister is currently, I think she's as one of the guardians as well. And I'm kind of in that process of becoming that as well, like the dual guardianship stuff. But I know in Wisconsin, I had to take a class on how to be a guardian, which is kind of ironic because I grew up with this. never knew anything else in my life outside of this. So I had to take a C.A.R.E class pretty much. But some of those challenges that we're facing currently with Grace is we have this great group of, we have these 7 girls and these 2 care providers generally at all times there. And I'm sure, as we all know, it's easy to find work, but it's that quality work for those people who actually want to be there to make a difference is always hard. And Grace, coming from our hometown, had some high school friends who were great, who stuck with us for a while. Some of them are still with us, some of them have moved on, but it's being able to continue to find those quality candidates who truly care and are not just there to get paid or to just to be there to be there. So it's always frustrating when I come back to that go visit my sister, and she's just on a couch sitting on her iPad, and it's like, oh, let's go outside, let's go sit outside, let's go shoot some basketball hoops and shoot some hoops, let's go do this stuff. So that's one of the big challenges now. And then we talked about the gait issues and the stability issues earlier on. That's the biggest challenge physically right now that I've noticed, just being back with her more regularly. Just seeing from that has seriously decreased recently, probably in the last 2 years in particular. It's going to continue to get worse, and kind of adapting and figuring out how we can still get that figured out, or if it's not going to get better, which at this point it probably won't get better, it's probably going to continue to get worse, how we can mitigate that and how can we work around that. Because at the end of the day, everyone in this room is in a difficult situation. We all have our own challenges, and it's how can we take that one step at a time to fix that one issue. There's hundreds of issues that we all have with our special person in our life, and it's how can we take those one step at a time, one day at a time, to figure out those goals. And it takes a whole community to do that. You got to rely on everyone who has those similar experiences. Rely on your family, your friends, especially the ones who understand this situation to the fullest and understand the complexity of what goes into it. Being able to just kind of brainstorm, whether it's like, okay, how do we find those good care people? Where are the places that we can look? Those are some of the big things that we're currently kind of figuring out. Future goals, obviously, kind of keep status quo is good. That's what we've learned, is if you can keep the status quo, keep that job, keep that care pretty similar across the board, that's a good thing. Obviously, there's things that we want to change, like activity-wise, whether at Special Olympics or just any other activity that she does. And getting in, and we talked about those routines earlier as well. Getting those well-established routines, the toileting, the eating healthy, not just overeating. Of course, I'm sure we've all seen, everyone loves cheese, and that's one of the big things my sister likes. And if you put a block of 10 pounds of cheese in front of her, she'd eat the whole thing if she could.
Well, it is Wisconsin.
Oh, well, okay, maybe. But I don't know. I've talked to people here before, and it's the same way. There's different vices that, whether it comes to food or TV or stuff like that, that it's how can we limit that, but not necessarily cut it out, because cutting it out at the end of the day is not going to be, it's not going to be feasible, as it's just not worth that much of a difficulty to try and just take something out like that totally. So yeah, moving forward, it's kind of just, as I said, one step at a time, work with those people around you. It sounds like the majority of the people, it's older groups here with like older siblings, but just looking back a little bit to how I grew up with handling a sibling with Dravet, and how my parents especially went about raising us in that aspect. I think it speaks a lot to just my parents as who they are and how they wanted to raise us, how they wanted to raise us as a family group. Yes, we're going to have good days and we're going to have a lot of bad days, but life goes on and you have to adapt. If there's a seizure at a soccer game or at a football event or at a game that we're at or anywhere in general, how can we redirect and kind of work through that as a family unit and figure out what's the next step? If we need to divide and conquer, we divide and conquer. If we need to all go home, we all go home. And as young siblings, it's hard. As a 5-year-old or a 7-year-old or a 10-year-old, you're not understanding why I'm going home because I wanted to be at this Wisconsin football game. Why do I have to go home? I thought we could stay. And as they get older, they're going to understand. It's tough to comprehend. It's tough to, as a 5-year-old, 7-year-old, you just don't understand. You just can't comprehend that. And at the time, there may be behavioral issues in those kids. I know I was a crazy kid myself, a lot of energy, lashed out once in a while. And it's how you react to that. It's part of life where you have, as parents, you have to be there to understand that there's a lot going on in the whole family unit. If something happens with those other siblings, it just happens in that aspect of life. And as life goes on, they will understand it. It will take time, but the understanding will come as those younger siblings mature and understand the true aspect that you can't control what's happening right now, and you just have to work together. So I'm going to hand it over to Cameron.
Thank you so much, Murphy. Appreciate you sharing the future and also a look back at the past. That's very helpful. And now over to you, Cameron. We'd love to hear your perspective.
Awesome. Hi, everyone. My name's Cameron Dodd. You heard from my mom a bit earlier, Kathy Dodd, so I'll try not to repeat myself or repeat anything you already heard, but I missed parts of my mom's talk because I was chasing my beautiful sister around the hotel. I'm a little bit older than Stacy. I'm about 2.5 years older than her. I'm 28 and Stacy is 25, about to turn 26. Stacy developed her epilepsy very early on in life when she was 8 months old. So the Stacy with Dravet syndrome is the Stacy that I grew up with and we've known for quite a while now. Stacy and I have a very, I think, regular sibling relationship. And curious, are there any siblings in the room, or is it mostly? Okay. Besides. I'll try to gear my thoughts more towards the parents, but I'd say one thing that I appreciate a lot about my relationship with Stacy is she's taught me so much, but I've tried to maintain as much of a normal sibling relationship as possible. I think it's very easy for siblings to fall into more of a parental guardian role. And I think it's really important for parents and siblings to focus on those normal aspects of life when everything else doesn't feel very normal. So Stacy and I like to bug each other all the time. Being the older sibling, Stacy does tend to copy everything I do. If I'm gonna take a shower, Stacy wants to take a shower. If I'm getting coffee, Stacy wants coffee. And we seem to share friends, and Stacy, I think, even would love to share romantic interests, but we try to keep those separate. But that's one thing that has been very grounding in my relationship with Stacy, is that we've tried to maintain as much normal in what seems abnormal. Stacy went to public school until she aged out of the schooling system at 22. That happened during COVID, and I think my mom briefly mentioned that, but it kind of faltered her transition into where she would be long-term in adulthood. I'm sure a lot of families here had a lot of difficulties with COVID in general. Our hope is for Stacy to move into a long-term care facility in the Chicagoland area where my parents are and where I'm currently living. The process to transition her into that home has been, I think, not just long, but longer than we anticipated. My parents found this home when Stacy was very young, I think between 5 and 10 years old, and immediately put her on the wait list. When she started to get to the age where she was transitioning out of school, the conversation started to pick up in terms of when Stacy could move in. And we've been talking to them and trying to transition her now for about 4 to 5 years. And I think we're getting close, but there's just a lot of intricacies that have to happen with these various homes in order to get our loved ones where we want them to be. I will say to the parents in the room, it's so important to involve the siblings as much as possible in the conversations that are happening around long-term care. I saw a note in this binder about how I think maybe parents can feel like if there's not a solid plan in place, they don't want to overshare, they don't want their siblings to feel anxious or uncomfortable, but there's never really going to be a solid plan. We know with our family members, everything's constantly changing, so I think communicating as much as possible is really, really important. I know from what I've seen with my own parents, and I think what I've learned about is a lot of the time parents don't want siblings or extended family or other caregivers to feel a burden of their siblings. But I think on the other end of the spectrum, for the most part, loved ones really want to be involved. So sometimes it can even feel hurtful if you're not part of those conversations. I myself try to attend a lot of the conversations that are happening with the long-term care facility Stacy is going to be living in. It's definitely tough, but my parents have done a great job, so I feel lucky to just be in their presence and kind of take everything in. Another thing that I think is really important, and Murphy, you mentioned too, is keeping your base of care and your base of loved ones really close. So not just assuming that it has to be the parents that are going to look after your loved one. My parents have done an exceptional job in keeping in touch with Stacy's friends that she's made throughout her life. She has friends that she made in grade school that are still very involved, some teachers that she's remained very close with, and those have become resources for me as well to learn from, kind of lean on when needed, and also build up a framework of care around Stacy that's not just my parents. So really, really trying to keep those loved ones, friends, extended family close. Again, I know it can feel like a burden, but I think it's actually quite the opposite. I also felt very humbled when I was able to keep in touch with people that I met with other needs throughout high school and maintain those relationships on the other side of things. So I think it's something that if someone is in your life and they really care about your loved one, I think they want to be there for the long haul. And then I think that's most of what I wanted to cover. Again, definitely just over-communicate. Even I know my parents and I struggle to talk through everything. It can be easier to put things on the sidelines or not want to address those tougher topics, but bringing your extended family siblings into every conversation is important. I know even like when Stacy's medication changes, it might not seem like something that I need to know, but then I'll be at the house giving her medicine when I'm hanging out with her, and I feel like I have no idea if I'm doing the right thing. So just doing as much as possible to bring your sibling and really anyone in the care routine into the conversations is important. And then the last thing I'll say is definitely encourage your siblings if they do want to be involved with various organizations that your loved one is in. Look for sibling organizations. There's sibling organizations that I'm involved in with the long-term care facility that my sister will be in, and even forums like this where I've been able to meet other siblings, it makes all the difference. So definitely bring your kids in, and always remember how much they want to be involved, because I think they typically do.
Wow. Thank you so much, Cameron, Murphy, Greg, and Janice, for all the amazing insights and perspectives. It's very, very helpful. And I'd like to take an opportunity to allow the audience to ask one more last round of questions. And I see we have a hand up in the back.
Okay, I came in a little later on this talk, so I don't know what was brought up before this, but so I have a 19, almost 20-year-old sibling. My Dravet kiddo is 10. So it's a little bit different, but I did want to ask the siblings, did y'all go off and do your own thing for a little bit and then come back? Because that's what my daughter, we moved, sorry, I'll try not to take too long, I'll try to wrap this up. We moved recently a year ago, and she had graduated from high school. But she came with us on the move, but she recently moved, you know, and we wanted her to do that. We wanted her to go and kind of live her own life. And so my question to you was, did y'all do that? Did y'all go and do your own thing? Or and like I said, I came in late, so I don't know, but it's hard having an older, and I think it's different. I can't remember which one of y'all said, but so my daughter is not the Dravet, she's the oldest, and she's the sibling. And so she was, I feel like growing up, she felt like she always had to be like a caregiver with us. And so now I'm so happy that she's to that point where she wanted to get out and do something. And I don't know, I just wanted to see y'all, the siblings' thoughts on that.
Yeah, that's great. I moved away I went to school out of state. So I went to school 4 years in Ohio, so about an 8-hour drive away from home. Obviously, I'd come back for the holidays and for a few summers here and there. I think it was a great opportunity for me to, as you said, get away, kind of take my mind off things a little bit. I'm obviously I'm gonna still be involved in those conversations. When things go bad, I'm probably gonna hear about them. But yeah, as you said, that burden when you're younger, I've talked about it with my older sister, and she's like, yeah, I kind of felt that same burden before. That responsibility as kind of that caregiver when you're still a kid is kind of a burden in general. Like it's what's going to happen, and I think that's kind of human nature to think that you have to be involved. My parents did a good job of encouraging me as well to get out, and I would continue to always encourage that. It's good to go see different things, experience different parts of life, different places, and you're really going to grow as yourself away from that as well, on top of all the things that you learned as you grew up with that sibling with Dravet. So just in short, I got away. I think it was great, and I'm actually now back in town with my rest of my family as well. So kind of turned full circle.
You know what?
I think very similar experience on my end as well. And I really like this question because I think it's really important. My parents also did a really good job in encouraging me to do what I wanted. I went to college pretty far away. We're from Illinois, and I went to school in Florida for 4 years. And I remember as a high schooler really struggling to know what I wanted to do, and I actually really didn't want to leave my sister. I think that was one of the hardest parts of college. But I did, and I think it really gave me a good perspective on how involved I wanted to be with Stacy, my siblings, overall care. So I think it's really important for parents to encourage their children to follow their dreams and do something else, so they can really kind of evaluate and learn for themselves how much they care and love and want to be involved with their siblings, kind of later adulthood. But I definitely think it was important. I missed my lovely sister who's smiling at me a lot, and I think the more that we can encourage siblings to get outside of their comfort zone, because I think our special families become the comfort zone, the more that they'll be able to provide that level of care later in life.
Can I just say, as an older guy, probably the oldest one in the room, wow, what a couple of great siblings you are. I just got to give So kudos to the parents and the family, and I think it really does make you grow to be a better, well-rounded person to go through what you've done. But good job, both of you, and good job to the parents.
And I just wanted to get a little different perspective. I actually take care of my brother who's schizophrenic and my mom who's also physically disabled. And, I am very happy to do so, but I had my family. I was married at the time when my dad passed away. We bought my parents' house, and so I took over the caregiving for them as well. And I would not want that burden for my children. My daughter and son, who have spoken on the sibling panels at other conferences, my wish for them and my hope for our family is that they go out and they have their best life and they have their own families. And if they would just keep their sibling as part of their family, and in the future, if they will spend time checking in on them or visiting them, taking them on a vacation every once in a while, those kind of things, that is my best wish for them all, that they can remain close, but they can also have their own lives. And, I don't want the burden on them. And I also don't think it's necessarily the best thing, even for my disabled children. The day program Emily is in, she's very happy. She's very happy to be around her peers. She's very happy to be, at that program. And I think she'll be fine when I find an appropriate residential program for her. I have my worries and qualms and all that, but I think they're going to be great. They're going to be fine, in someone else's care if you have good quality care. And wouldn't it be nice if they just had that normal sibling relationship where they got together, and if something happens to me and my husband, then those siblings are still there and they want to be there, and they have a great relationship like these guys do with their siblings. And, they are willing to take out some of the time of their life and take them on a trip. Or, my children are very involved with the disabled siblings, but that's by their choice, and it's not a matter of them living with them or having the day-to-day care of them, but just the fact that they're there for them in all those other ways is phenomenal. So again, I also applaud you guys for being super siblings. So.
Yeah, and I'll just add one more thing that I was thinking about while you guys were talking. Just because a sibling might go far away or pursue a certain life that might not be directly related to their sibling doesn't mean they don't want to be informed. So keep them informed, keep them up to date, even when they're gone. I think it's just important for them to know what's going on. We want to know. So.
Thank you so much. I think we have time for one more question, and then I want to bring up somebody very special to share a special story with you all. So let's have this last question if we can.
First off, thank you, siblings. You give us hope that our 10-year-old will get there someday. But then the second thing is the residential home care. That kind of floors my mind that that's even an option. We're at 12 years old, so we've got some time. But how do they deal with the overnight seizures or the seizures while sleeping if there's only nursing there during the day? Does that make sense? Like, how does that work or not work within the residential care homes?
So we have a really cool situation actually with my sister. So there's a company called Night Owl. They do monitoring generally for, let's say, the people who, it starts at like 9 o'clock at night. And at 9 o'clock at night, someone comes in, and generally it's like an a veteran or an EMT or someone who has the experience handling tough situations, and their job is pretty much to cover we'll say a radius, like a 5-mile radius from this home, wherever that is. And obviously with Dravet, you can't, or with seizures, you can't have them be 5 miles away. That's just not feasible. So how we have it set up at the location is they were looking to expand and add another location where they could kind of have like a satellite location where if they got a call, they'd then go to wherever that location is. So how it's set up in our location is they're actually based out of that same building that my sister's based out of. I know growing up, that's different. So how that's set up, they have monitors at every door. They have a seizure pad. So when there's a seizure, an alarm will go off and they'll be able to come in. Growing up, there was a seizure pad and a monitor in my sister's room the whole time. Do you want to talk about how it works?
Yeah, it kind of goes back to the getting involved. If you can get involved in the C.A.R.E in your local, you can influence those things. Like we have 18 group homes. We didn't always have that, but being on the board, you can influence overnights. We have 24-hour care overnights. I think you brought up the emergency meds. We train people on our staff, and they cannot all administer drugs, but if there's a seizure, there's always someone in the home that can administer drugs, not just the middle of the day, 24 hours. So, I mean, I've been on so many of the committees, and that's where you meet, the rubber meets the road. When I was younger in the group, I happened to chair the committee that wrote the sexuality policy for our group homes, because that's an issue. You know, you have people in there that they sometimes act out. We had to address all those. We had other agencies asking us for a copy of the sexuality policy. But my point is, if you're involved when overnights come up or any of these issues, you can influence that. You can be there and help them solve it, add it as a new program to your agency, and make that agency grow. And the revenue stream is there. Medicaid will fund those things, transportation. So we just have continued to grow through the years, adding group homes when we can. And you guys can do that too. Just join your organization, get involved, have the dream, like these folks have had the dream for the Dravet Foundation. It wasn't here not long ago. I'm just encouraging you to get in there and fight for what you want.
Okay, I always have to be the negative one. There's never going to be a perfect fit, and that's why Emily's not in residential right now. So she's 26, and 5 years ago it wouldn't have even been a question because her seizures didn't stop without emergency meds immediately. So now her seizures are lasting, they're like 3 to 5 minutes, and they are resolving more on their own. However, I haven't found a facility other than a nursing home that will take her and monitor her through the night for seizures. And Emily does what I call the death roll, and she rolls over on her face every seizure, and then I have to go flip her over. And the seizure is only 3 minutes long, but if she's on her face, then you don't know what's gonna happen. And so there are like all sorts of residential programs. There are community homes where you have a home in the community and you have like say 8 people living there and they have someone there, but they're not watching her. They have intermediate care facilities that have 24-hour nursing. Again, they will go by the room every 15 to 30 minutes, but how long does it take if she happens to suffocate? And then there's the nursing home, which she would get in, and I could get her 24-hour nursing where they're actually monitoring her. but the youngest person there is 65. And so these are difficulties that our family is going through and other families, I'm sure, are going through. But what I love about this gentleman is, there is hope, and I think you just have to really advocate, and you have to go, and that's what we're doing right now. We're in the stage of really working with the local organizations and saying, these are not good fits for my child. What do I need to do to get to the point where I'm comfortable leaving her in an overnight situation where she's seizing and flipping onto her face? So I'm not there yet, and I've been working on it for several years, but I think we're getting closer. The caveat being Emily's seizure pattern has changed where it's making it more of a possibility. But 5 years ago, she needed immediate rescue meds. And so it really is dependent on where your child is at that time when you're going to try and get residential. Therefore, what I'm saying is there's families out there that are choosing to keep their family at home because of those reasons. And so one of the things we also need to advocate for is better care, because it's not just epilepsy, it's just not Dravet kids. There's a whole host of disabilities that really don't fit into the current residential programs that are available out there. So I don't have the answer, but I think that's something we all need to work for together. So.
Thank you, Janice, and thank you to our panel. Let's give them a round of applause for sharing all their amazing insights.